Hi guys, am I audible and visible to you properly? Please give me a thumbs up if I am audible and visible to you. Okay guys, yeah, if I am audible and visible to you, please give me a thumbs up. Hi guys, am I audible and visible to you properly? Yes. Okay, good, good. Okay, guys, so what we are going to do, we are going to discuss a set of 60 questions today, and we are going to do it in a bit rapid manner. We'll try to wrap up the session by 12 o'clock, and that's what's the aim over here. Okay, so I want you to be a bit active. I want you to kind of answer the things in the kind of comment box. So yeah, please kind of let's get started with this. Okay, so identify the condition which is shown in this particular figure. What is the underlying cause? Okay, so what I'm trying to ask you, what is this particular condition, and what is the underlying cause of this particular condition? Okay, so what do you think? What is the answer? Now, I hope that you're answering that the answer to this particular question is subdermal lymphatic. So what you're basically seeing on this particular question is that there is a body orange. Okay, so body orange appearance is there, and this is because of the involvement of a subdermal lymphatics. Okay, now a similar kind of question can be asked to you. They can ask you that there is a let's say 45-year-old postmenopause lady presenting with the following appearance of the breast. What is the T stage of this particular cancer? So can you please help me? What is the answer over here? Is it like a T4A, T4B, T4C, T4D? What is the answer over here? Okay, so yeah, can you please help me with this? What is the answer over here, guys? So I hope that you're answering that the answer over here is T4B. Okay, so what is the answer? Answer is T4B over here. Okay, so this is the basics about what you call as the breast, which you need to understand. So what I'll do, I'll just cover the basics of the breast with you guys. Okay, so what I'm going to do, I'm going to cover the TNM staging of the breast with you guys. Okay, so what I'm going to do, I'm going to cover the TNM staging. Just give me a minute. Oh, I do not have any blanks. I don't what. Just give me a minute. Okay, just give me a minute. So what I'm going to cover, I'm going to cover the TNM staging of the breast with you guys. Okay, just give me a minute. Okay, so guys, let's talk about the TNM staging. TNM staging of the breast. Okay, so first we are going to talk about the T stage. Okay, so first we are going to cover the T stage over here. What about the T stage? What guys, what you need to understand about the T stage? So that's what we have T1, we have T2, we have T3, then we have T4 A, B, C and D. Okay, so these are the things which you basically have in the T stage, right? So what is a T1? What is a T1? T1 is basically when the size of the tumor is less than 2 centimeters, but the tumor is basically limited to the breast. In the T2, the size is basically between 2 to 5 centimeters, and the tumor is basically limited to the breast. And the T3, the size is basically more than 5 centimeters, and the tumor is basically again limited to the breast. Okay, so that is what you need to understand over here. What about the T4? So guys, I'm pretty sure that most of you know about this particular T4A, whether it is a chest wall, whether it is a skin and all this particular stuff. But what you need to understand is that, yeah, so sometimes you might have a confusion. So how do you kind of remember it? That if at all there is an involvement of like, what is like whenever we kind of screw up in our life, what is the first person to kind of blame? Should we blame ourselves or should we blame the external atmosphere? So please try to understand, we should blame ourselves first. Okay, so we always have to do the self introspection first. Okay, so what is the T4A? T4B is basically involvement of the chest wall. Okay, and what about the T4B? T4B is involvement of the skin. Now the question which they keep on asking is that what is considered to be as a part of the chest wall? Okay, so what is considered to be a part of the chest wall? So if at all there is involvement of the ribs, if at all there is involvement of the intercostal muscles, if at all there is involvement of a serratus anterior muscle, so this is what is considered to be a part of a chest wall. Okay, so all these particular things are considered to be a part of the chest wall. What is not considered to be a part of the chest wall? So pectoralis major and the pectoralis minor. Okay, pectoralis major and the minor muscles, these are not considered to be the part of the chest wall. What about the skin, guys? Okay, what about the skin? So what about the skin? Okay, so in the skin, if at all, let's say the question mentions that there is body orange, or if at all the question mentions that there is what you call as a ulcer, or if at all the question says that there is a nodule, then all these particular things are considered to be a part of a chest skin, okay? But if at all the question mentions that there is dimpling, there is nipple retraction, okay, so this is not considered to be a part of the skin, okay? So this is not considered to be a part of the skin, okay? I hope you are able to understand this point. What about the T4C? T4C is when there is involvement of the skin plus the chest wall. And what about the T4D? T4D is basically inflammatory breast carcinoma, okay? So what is the T4D? T4D is basically inflammatory breast carcinoma. So I hope you have understood this particular point. So this is what is the TNM staging for the patients with the breast cancer, okay? Now what about the end stage? Let's talk about the end stage of the patients with the breast cancer. So in the end stage, what do we have? We have N1, then we have N2, which is N2A and N2B, then we have N3, which is N3A, B and C, okay? So these are the things which you basically have. What about the N1? In the N1, what you have axillary group of lymph nodes, and they are axillary lymph nodes which are mobile. So mobile axillary lymph nodes, this is what is N1. What is N2A? This is fixed or matted. If at all the question mentions that there is fixed or a matted axillary lymph nodes, this is what is the N2A. What about the N2B? In the N2B, there is an internal mammary group of lymph nodes, okay? What about the N3A? In the N3A, there is clavicular group of lymph nodes. In the N3B, there is axillary plus internal mammary group of lymph nodes, and what about N3C? This is supraclavicular group of lymph nodes, okay? So please try to understand, these are very important, okay? So I hope you have understood about the T and the end stage of the patients with the breast cancer. Now let us move on to the next question, okay? So now let's move on to the next question. So what are you able to understand over here, okay? So if I ask you that there is a 55-year-old female patient with a history of a mastectomy which was done 3 months before, and there is a swelling of an ipsilateral kind of a limb, there is no pain, and this is non-tender. What is the diagnosis of this particular patient? It's one of the simplest questions ever. So what are you dealing with? This is what is your lymphedema. So please try to understand over here. This is what is a lymphedema. Okay, so here I hope you're able to appreciate that there is a skin which is basically the normal looking skin, but it is just that it is kind of swollen. Okay, so this swollen and the edematous kind of a skin. So this is what is your lymphedema. Okay, so what you need to understand about over here, let's say if at all there is a patient who is being operated for a modified radical mastectomy. Okay, so if at all there is a patient who is being subjected to a modified radical mastectomy. So once the patient has been subjected to a modified radical mastectomy, and let's say if at all there has been an aggressive lymph node dissection, or there has been post-operative radiotherapy. So all these particular things what can do is they can basically hamper the lymphatic drainage from the upper limb. Okay, so this can hamper the lymphatic drainage from the upper limb, and because of this the patients may develop lymphedema. Okay, so because of this the patients may develop lymphedema. Are you understand my point? So because of this the patients may develop lymphedema. So what is the lymphedema? This is basically having the normal looking skin. This basically is there, and this is basically present for a prolonged period of time. Now let me just tell you about what is the transformation of the lymphedema to a lymphangiosarcoma. So what you need to understand is that if at all in that normal looking kind of a skin, if at all there is development of nodules, or let's say there is hemorrhage, okay, so they might tell you that, you know what, the patient had a lymphedema which was there for a prolonged period of time, 8, 10, 20 years, whatever, and now the patients have developed this particular nodules and the hemorrhage over the surface of the skin. This is what is a lymphangiosarcoma. And what is this called as? This is what is called as a Stewart-Travis syndrome. Okay, so what is this? This is what is the Stewart-Travis syndrome. I hope you are able to appreciate that this is what is referred to as your Stewart-Travis syndrome. Okay, everybody is okay with this? So this is about the transformation of lymphedema into the lymphangiosarcoma. Okay, now let's move on to the next particular question. So yeah, please tell me this particular answer. What is the answer over here? That there is a patient who presented with a lump in the breast. Okay, so there is a patient who presented with a lump in the breast and she was diagnosed with a stage 2 breast cancer. Now she underwent a mastectomy for the breast reconstruction. Which of the following is the best flap ever? Okay, so which is the best flap out of these particular four? What is the best flap? Can you please help me with this? What is the best flap over here? So please try to understand. The best flap which you have over here is type C. Okay, so what is this? This is what is called as a DIEP flap. This is what is your what you call as deep inferior epigastric pedicle flap. So this is what is a deep inferior epigastric pedicled flap. This is what is your free flap. Okay, what is this? This is what is your free flap. Okay, so this is what is your free flap, and yeah, that is what you basically have in this particular DIEP, deep inferior epigastric pedicle flap. This is what is a free flap. I hope you are able to understand this point, and this is also the best flap which we have. Okay, so this is also the best flap which we basically have for the patients for the breast reconstruction. Okay, now what is this? What is this? This is okay. So what is this? This is basically a type of a tram flap only. Okay, so this is a tram flap, but this is a free flap. Okay, so this is free type of a tram flap. What is this? This is again a tram flap, but this is what is called as a pedicled. Okay, so this is a pedicled tram flap. Okay, so what is this? This is what is a pedicled tram flap. So this is again good one, but the best one is definitely this DIEP. Why it is called as a DIEP? Because it is based on the deep inferior epigastric pedicle. Okay, so that is what you need to understand over here. Okay, now let's move on to the next question. There's a 14-week postnatal woman presented with the breast swelling. Which of the following is the most common treatment for this particular patient? What do you think? What is the treatment over here? Can you please help me with this, guys? Okay, so there's a patient who presented with a fluctuant breast swelling, 14 weeks postpartum. What is the kind of, okay, so here, please do not mark it as incision drainage. This is the most common wrong answer which we usually get. The answer over here is a repeated aspirations under antibiotic cover. So please try to understand. Answer over here is D. Very, 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 very important. So what is the diagnosis of this particular patient in this question? So please try to understand. The diagnosis of this particular patient is what you call as breast abscess. Okay, so what is this? This is what is a breast abscess. Okay, now if I ask you what is the most common cause of this particular breast abscess, so most common cause of the breast abscess, so what happens is that in the postpartum period, okay, so in the postpartum period, what can happen is that there can be nipple cracks can develop, and from there what can happen, the staphylococcus, the staph basically finds its way to the breast, and there it basically leads to the formation of a breast abscess. Okay, so first thing what you need to understand, why this is happening, because of the nipple cracks. And what is the most common organism which is associated with this? Is a Staphylococcus aureus. Okay, so most common organism is your Staphylococcus aureus. I understand my point. So this is what is the pathogenesis of development of the breast abscess. Okay, now what you need to understand is that many times people mark it as, okay, so this is, there are two things which they're going to ask you. They'll ask you to diagnose it. So in the diagnosis, what you need to understand, that the patients are going to have that particular fluctuant swelling, and there will be changes of the skin, there will be let's say tenderness of the skin, there will be kind of increased temperature of the skin, all those particular things are going to be there. Okay, now in this particular, this is how the patients are going to present to you. Finally, it is about the treatment. Okay, so please try to understand that earlier what we used to think that, you know what, we may perform an incision and drainage. This is not the correct treatment. Okay, incision and drainage was kind of considered as a good treatment, let's say 10 years, 20 years back, and there they used to say that you give a radial incision and all those particular stuff, but all this particular concept has been discarded now. This has been discarded. In today's time, what is the treatment of choice for this? So the treatment of choice is basically aspiration of the abscess under USG. Okay, so ultrasound guidance, and obviously along with this you are going to give the antibiotics to the patient. Okay, so you're going to give the antibiotics to the patient. Okay, so please try to understand over here. You are going to give the antibiotics and you're going to kind of do the aspiration. Now, what about if at all there is a recurrence? If at all the recurrence happens, now what you're going to do? Even after the recurrence, your management will be the same. You will still go ahead with the aspiration. You will continue to aspirate it multiple times. That is what you are going to continue to do that. Okay, right? Okay, I hope you're able to understand. Even if there is no. Okay, so I hope you got the answer, Shubhank. It is like you will not go ahead with the even if there is multiple abscess, you will go ahead with the aspiration of every kind of abscess. Even if there is a recurrence, you will continue to kind of do this aspiration. Okay, so please try to understand why you're not wanting to do an IND, because if you perform an incident drainage, what is going to happen? Invariably, you are going to damage certain breast ducts, okay, the mammary ducts, and from there, what is going to happen? The continuous milk will continue to kind of leak, which you don't want. Okay, so that is why what you basically want is you want that the abscess should kind of subside down and you basically aspirate it again and again. And yeah, I hope you're able to understand this point. Okay, now I'll answer the couple of questions. Now, many of the people have, like a couple of people have like Shivang has already kind of given the diagnosis as mastitis. That is not a mastitis. It is a clear-cut diagnosis of a breast abscess, because they have given you the fluctuant swelling. The fluctuant breast swelling is not going to be a part of your mastitis. Okay, so please try to understand the diagnosis over here was a breast abscess. It was not a mastitis. Okay, it was not the mastitis. Okay, I hope you have understood this particular point. Okay. Now, let's move to the next question. What is the most common cause of the chronic pancreatitis? It's one of the simplest questions which you can get. So can you please help me? What is the most common cause of a chronic pancreatitis? It is alcoholism. Okay. So once an alcoholism, like alcoholic, always an alcoholic. So yes, what is the answer over here? It is the most common cause of chronic pancreatitis is an alcoholism. Okay, that's fine. Okay. Now, another important thing, if I ask you, what is the most common cause of acute pancreatitis? Acute pancreatitis. Can you please help me with this? What is the most common cause of an acute pancreatitis? So the most common cause of an acute pancreatitis is, okay, so the most common cause of the acute pancreatitis is what you call as a gallstone. So what happens is that the gallstone basically travels down from the common bile duct, and then it basically enters into that common pathway when the kind of common bile duct and the pancreatic duct, they basically join with each other, and now they are going to open at the major papilla, right? So what you need to understand, if at all that stone is obstructing that particular common pathway, then there is a risk of an pancreatitis which can happen, and that is the most common cause of your acute pancreatitis. Please try to understand that. Okay, please try to understand. And what about the ERCP? ERCP, can it lead to the acute pancreatitis? Yes, it can lead to the acute pancreatitis. Okay, so the kind of percentages have changed, but earlier it was thought that around 5% of the patients with pancreatitis land up into acute pancreatitis. Now the percentage is around 2 to 3, but what you need to understand is the most common complication of ERCP. This has been asked to you in the FMG just in the last session. Okay, so the most common complication of an ERCP is an acute pancreatitis. I hope you are able to understand this point. Okay, so the most common complication of an ERCP is an acute pancreatitis. Somebody is asking about the phyllodes tumor. So phyllodes tumor is entirely different. Phyllodes tumor is basically a benign tumor of the breast which basically grows to a very massive extent. How do you diagnose it? You basically diagnose it by the bossy-lated swelling. So if you go and feel that particular stuff, what is going to happen? There's going to be what you call as a heterogeneous bumpiness of the kind of a breast. But yeah, that's what is going to be in the on the feeling. And the important thing is that the phyllodes tumor is never ever attached to the breast. Okay, it is never ever attached to the underlying chest wall. It is a benign tumor, but it is locally aggressive. It is called as a phyllodes tumor. Why? Because on the cross section it basically appears like a leaf. Okay, so it basically like the cross section, like in the histopathological examination, the things basically appear like a leaf, and that's what you need to understand over here. It's a stromal tumor. Yeah, that's fine. Okay, so it's a benign tumor, but it has a malignant potential. So you have to perform a wide local excision, but most of the times it is basically involving the entire breast. So you end up performing a simple mastectomy over here. It is not a sarcoma. It may get transformed into a sarcoma, but it is not a sarcoma. Okay, now this is an important kind of a thing. So what you need to understand, what is the name of the surgery whose image has been kind of given below? So can you please help me with this? What is the name of this particular surgery, which the image which has been given below? I'll just enlarge the image for you guys. So what is the name of the surgery? I want you guys to answer. So what do you think? What is the answer? Now this has been asked to you in the FMG exam, guys. Okay, so please tell me. Okay, right. So yeah, what is the answer over here? It is pancreatico Come on, guys. Okay, so this is what is called as a longitudinal pancreatic or jejunostomy. Okay, so obviously it's as simple as that. You have opened the pancreas longitudinally and you're kind of attaching the jejunum over here. So this is what is a longitudinal pancreatic or jejunostomy. Okay, so it is a longitudinal pancreatic or jejunostomy, which is basically referred to as your Pusto's procedure. Okay, so what is this? This is what is called as a Pusto's procedure. Okay, so Brewster's procedure. Now before I move ahead, somebody is asking, what if the phyllodes tumor is malignant? Then what you're going to do? Obviously you're going to do a kind of a mastectomy in totality, and if at all the lymph nodes are enlarged, you will go ahead with a like a modified radical mastectomy or something like that. Okay, are you understanding my point? So you'll have to kind of go ahead with the lymph nodes as well, and you have to kind of also give what you call as a radiotherapy. So this is not Kasai, this is not a Roux-en-Y. Please try to understand, this is a longitudinal pancreatic or jejunostomy or the Pusto's procedure, which is basically the surgery for the patients with chronic pancreatitis. Okay, so this is a surgery for the patients with a chronic pancreatitis. Okay, so whenever you come across a patient with a chronic pancreatitis, okay, so whenever you come across a patient with a chronic pancreatitis, what do you think? What is the major problem with these particular patients? Okay, so what is the major problem? So these particular patients will have exocrine insufficiency. This basically means that whatever the sufficiency, this basically means that, you know what, the lipase and the protease, all those particular things will not be kind of be present in an adequate amount in these particular patients, and that is why the patients are going to have malabsorption. Okay, so patients are going to have malabsorption. Then what you need to understand, the patients will have an endocrine insufficiency, and because of this, what the patients are going to have, because of this, the patients are going to have diabetes and other kind of things. Okay, so because there will be insulin deficiency, because of this, the patients are going to have diabetes and other stuff. Okay, but the important thing is the pain. Okay, so what you need to understand is that if at all the patient is having malabsorption because of this exocrine insufficiency, this can be kind of taken care of. You can give the patients oral enzymes, amylase, lipase, everything can be given, and this can be taken care of. What about then endocrine insufficiency? If at all the patients land up into diabetes, even that can be taken care of. You can give these particular patients insulin from outside, and the diabetes can be taken care of. Are you understand my point? But the management of the pain is a major issue. Okay, so pain management is a major issue, and all these particular surgeries which you would have heard of, I think so, Pusto's procedures, Beggar's procedures, all these are the surgeries which you basically perform for the chronic pancreatitis when we are wanting to manage the pain in these particular patients. Okay, so when you are wanting to manage the pain in these particular patients, then what you end up performing is this Pusto's procedures, Beggar's procedure, all those particular things have to be performed. Okay, I hope you are able to appreciate this particular point. Okay, now what I'll do is I'll just walk you through how do you manage a patient of a chronic pancreatitis. So whenever you have a patient with a chronic pancreatitis, first you basically go with the conservative management. In the conservative management, what you basically do is you give the patients painkillers. Okay, you give the patients painkillers and all those particular stuff. If at all the patients respond to the pain, that's great. That's absolutely great. But if at all the patient doesn't respond to the pain, then you have to distinguish whether the patients are having a large duct disease or a small duct disease. What do you understand by the large duct disease? It means that there are multiple dilatations and the multiple strictures in the main pancreatic duct. So large duct disease basically means that it is the main pancreatic duct which is getting involved over here. So if at all the main pancreatic duct is the one which is having the problem, there are multiple dilatation strictures in the main pancreatic duct. In this particular scenario, first you advise the patients to go ahead with the endoscopic procedure. So you ask the patients to kind of subject the patients to what you call as an ERCP with the sphincterotomy, ERCP with the dilatation, ERCP with the removal of the stones from the pancreatic duct and everything. But if at all this fails, then you perform the surgical procedure. So what is this particular surgical procedure? This is what is called as a drainage procedure. This is what is called as a drainage procedures. Okay, so please try to understand. This is a repeat question from your what you call as FMGe. So please pay attention over here. So this is what is these are the drainage procedures. What are the drainage procedures? I'll talk to you about. But if at all, let's say there is a small duct disease. Small duct disease means that there is a parenchymal inflammation is there. So what is the main problem? There is a parenchymal inflammation inflammation. Okay, so patients are having a lot of parenchymal inflammation. Are you understand my point? So if at all the predominant problem in these particular patients is the parenchymal inflammation, in that particular scenario, you give these particular patients antioxidants and the celiac plexus block and all this particular stuff. But if at all this fails, okay, if at all this fails, then you have to perform a resection procedure. So I hope you're able to understand there are two types of procedures. One is basically called as a resection procedure. Another one is called as a drainage procedure. Drainage procedure is basically done when there is a problem in the main pancreatic duct. So as you can see in this particular image, what is the problem? I hope you are able to appreciate that there is the multiple dilatations in the main pancreatic duct. Okay, and that is why what is the procedure which has been performed over here? This is what is a Pusto's procedure, that is a longitudinal pancreaticojejunostomy, which is a type of a drainage procedure. Okay, so let me just walk you through it and then I'll show you the images and everything. So I hope you have understood where we perform the drainage procedure, where we perform a what you call as a resection procedure. So I'll just summarize it for you guys. If at all you have a large duct disease, what do you understand by the large duct disease? That is the main pancreatic duct is having a lot of dilatations and stricture. So in this particular scenario, what you have to perform is a longitudinal pancreaticojejunostomy, which you basically called as a Pusto's procedure. Okay, so this is what is called as a Pusto's procedure. So here what you basically do is that there is a pancreas. What you basically do, you open the pancreas like this. Okay, so you longitudinally you open the pancreas, you bring a jejunum and you attach it over here. So this is what is called as a longitudinal pancreaticojejunostomy Pusto's procedure. But if at all, let's say there is a small duct disease. So in the small duct disease, what you basically perform, you perform a resection procedure. So what is the name of this particular resection procedure? Please brace yourself. This is what is called as a DPPHR. Okay, so DPPHR, that is duodenum preserving pancreatic head resection. Okay, duodenum preserving pancreatic head resection. So this is what is called as a beggar's procedure. Okay, so this is what is referred to as your beggar's procedure. Okay, so this is what is referred to as your beggar's procedure. Are you understand my point? Duodenum preserving pancreatic head resection. This is what is referred to as your beggar's procedure. So as you can see over here that you have okay, so please try to understand. Now this is an image. This is what is an image of a beggar's procedure. So what you're basically doing over here, you're removing the head of the pancreas, but this part, a small rim of the pancreatic tissue is still kind of remaining over there. Why you want to kind of preserve it? Because over here, what you have this bile duct. Okay, and the bile duct is kind of coming and opening over here, right? So here there is a gallbladder, there's what is a like a hepatic duct, all this particular stuff, right? So you want to preserve that, and that is why you leave this thin rim of the pancreas over here. So this is what is called as a duodenum preserving pancreatic head resection, beggar's procedure, which is a type of a resection procedure. And we have already seen this. This is what is a Pusto's procedure. This is what is a longitudinal pancreaticojejunostomy. So for now, just kind of pay attention towards these things, and that's kind of okay. That's okay. Forget about this. This is what is a phrase procedure. Let's not get into it. Just remember the two procedures which we talked about. Longitudinal pancreaticojejunostomy, which is basically the Pusto's procedure, and then we have a duodenum preserving pancreatic head resection, which is basically called as your beggar's procedure. Okay, now I understand that this is a bit intense, but I hope you have understood. This is important. Yeah, but I don't consider that all these particular things are like AIMS level and blah blah blah, all those stuff. No, what I showed you, this was a question which was asked in FMG. So yes, it can be asked in any particular exam. So frankly, there is no major difference in the kind of the quality of the questions in the FMG and the NEET PG. The only difference is that in the FMG, all you need to kind of get is a 50% mark. That's it. Okay, but in the NEET PG, you have to kind of score good marks in order to get a good rank. Are you understanding? That is the only difference. But the quality of the preparation and the level of the preparation is broadly the same. If at all you want to kind of score really good marks in your FMG exam. I hope you're able to understand this point. Okay, now let's move on to this particular question. Identify the triangle in the image which is given below. Okay, so what is this particular triangle? So is this like a Cox triangle, Gastrinoma triangle, Hasselback's triangle, Sherin's triangle? So what is this? Yeah, what is the answer over here? Anybody? Can you please help me with this? So yeah, guys, the answer over here is definitely, it is called as a Gastrinoma triangle. It is also called as a Passaro's triangle. Okay, so what is this? Passaro's triangle or a Gastrinoma triangle. Okay, so what is this Gastrinoma and all those particular stuff? So this is, okay, so let's talk about the Gastrinoma. Let's talk about the pancreatic neuroendocrine tumors. Okay, so let's talk about the pancreatic neuroendocrine tumors. So what you need to understand is that one, you have insulinoma, and insulinoma is the most common. This is the most common pancreatic neuroendocrine tumor. So this is what is the most common pancreatic neuroendocrine tumor. Then what we have Gastrinoma. So this is the most common pancreatic neuroendocrine tumor in men 1 syndrome. So this is important. Okay, so if at all we ask you that, you know what is the most common pancreatic neuroendocrine tumor overall, it is insulinoma. But if at all somebody asks you what is the most common pancreatic neuroendocrine tumor in the men 1 syndrome, then the answer is going to be your Gastrinoma. I hope you are able to understand. Here the answer is Gastrinoma. Okay, I hope you have understood this point. Now let's talk about the Gastrinoma in a bit more detail. Okay, so let's talk about the Gastrinoma in a bit more detail. So Gastrinoma, is it like a benign or is it like a malignant? Please help me with this. Gastrinoma, is it like a benign or is it like a malignant pancreatic neuroendocrine tumor? So please try to understand, this is what is a malignant pancreatic neuroendocrine tumor. Okay, this is a malignant pancreatic neuroendocrine tumor. This is what you need to understand, the first thing. Okay, what is the second thing which you need to understand over here? That, okay, as I told you that this is the second most common and all those particular stuff. If I ask you what is the most common site of this, okay, if I ask you what is the most common site of this particular Gastrinoma, what is the answer over here? It is duodenum. Okay, so duodenum is the most common site of this. Okay, so this Gastrinoma, this basically comes like, this is basically occurring in the Gastrinoma triangle. Okay, this is basically occurring in the Gastrinoma triangle, which is also called as a Passaro's triangle. Okay, now what are the boundaries of this particular Gastrinoma? So what you need to understand, let's say this is the pancreas, this is the head and the body of the pancreas, then we have a second and the third part of the duodenum over here, and then what we have the cystic duct and the gallbladder. So the like the junction of the cystic duct and the gallbladder. So what you need to understand is that one point is basically between the head and the body of the pancreas, the other point is basically between the cystic duct and the gallbladder, and the third point is between the second and the third part of the duodenum. Are you understand my point? So these are the 3 points which you basically join, and this is what is your Gastrinoma triangle. Okay, so this is what is called as a Gastrinoma triangle or a Passaro's triangle. Am I making some sense to you guys? So please try to understand Gastrinoma triangle or the Passaro's triangle. This is what you basically get in these particular patients, right? Okay, got it? Now, okay, now what about the diagnosis? If at all there is a patient with a Gastrinoma, what is an investigation of choice? So what you basically perform is investigation. Okay, so what happens in this particular Gastrinoma? So this is a tumor which is rising from the G cells, and this is also, this Gastrinoma is also referred to as your Zollinger-Ellison syndrome. Okay, so Gastrinoma is also referred to as your Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome, Gastrinoma, one and the same thing. So here what you need to understand, investigation of choices, if at all you take the gastrin levels. Okay, if at all this particular gastrin level is more than 1000, that is what is your diagnostic. This is diagnostic. Okay, if at all the gastrin level is less than 200, this is what is normal. Okay, so if at all the gastrin level is less than 200, it is normal. But if at all the gastrin level is basically between the 200 to the 1000, this is what is referred to as your gray zone. Okay, so this is what is called as a gray zone, and in this particular gray zone, what you give these particular patients secretin. Okay, so what you give secretin, and once you give this particular patient secretin, what is going to happen? If at all the basal acid output, it increases by more than 200, then it is again diagnostic. Okay, it is diagnostic of the patients with gastrinoma. You understand my point? So when you basically kind of give the secretin to the patients in this particular gray zone, and if at all the basal acid output increases by more than 200, that is what is again diagnosis of the patients with the gastrinoma. I hope you are able to understand this particular point, guys. Okay, now what about the, okay, so we have diagnosed it, that's fine, but where in the body is this particular gastrinoma present? Okay, so for the localization, can you use the what you call as a somatostatin receptor scintigraphy? So yes, somatostatin receptor scintigraphy. This can be used. So what you need to understand is that in our body, whenever there is a neuroendocrine tumor, okay, so whenever there is a patient with a whenever there is a neuroendocrine tumor. So all these particular neuroendocrine tumors, they have one particular characteristic, that they have a receptor over it. What is this particular receptor? This receptor is basically called as a somatostatin receptor. So what is the name of this particular receptor? It is what is called as a somatostatin receptor. Now what we have the antibodies. Okay, we have these antibodies which are basically directed towards these somatostatin receptors. So if at all we put these particular antibodies into the blood, what is going to happen? These antibodies are going to go and they're going to bind to these particular somatostatin receptors. Okay, and what we can do is we can tag these particular antibodies by a radio labeled substance. Okay, so what we can do is we can tag these particular antibodies with a radio labeled substance. So now what you need to understand is wherever these particular antibodies are going to go and they're going to bind. So what are these? These are the somatostatin receptor antibody. What is this? This is what is your neuroendocrine tumor cells. Okay, and what is this? This is what is a radio labeled substance with which you have tagged these particular antibodies. Okay, so what you basically do is these particular antibodies are tagged by the radio labeled substance, and these particular antibodies, when they go and when they attach to these particular somatostatin receptors, now you will be able to localize it. Now what you need to understand is that every neuroendocrine tumor cells in our body are going to have these particular somatostatin receptors. So what I'm talking about, all these are the neuroendocrine tumors, like Gastrinoma, VIPoma, somatostatinoma, all these are the neuroendocrine tumors of the pancreas. So all these particular tumors are going to have the somatostatin receptor, and this is what is referred to as a somatostatin receptor scintigraphy. I hope you have understood this particular point, guys. Okay, now if I ask you which neuroendocrine tumor will not have these particular, will not be responsive for this particular somatostatin receptor scintigraphy, the only exception is insulinoma. Insulinoma, this is an exception. Okay, so this is an exception. These do not have the somatostatin receptors. Okay, so they do not have these particular somatostatin receptors, and that is why they are the exception. Okay, so here the somatostatin receptor scintigraphy is of no use. Okay, you understand my point? Somatostatin receptor scintigraphy is of no use in these particular patients because they do not have the somatostatin receptor. I hope you have understood this particular point, guys. Okay, everybody have understood this particular point? Yeah, got it, right? Okay, right. Now, okay, now if at all you want to talk about the intraoperative localization. Okay, so for the intraoperative localization, what you have for the intraoperative localization, what do you have for the intraoperative localization? For the intraoperative localization, you have ultrasound. Okay, so USG is there basically for an intraoperative localization, intraop ultrasound or an endoscopic ultrasound, whatever you want to kind of use, you can kind of use that. Okay, I hope you have understood this particular point. And what about the management? Management is basically surgical resection. Okay, so it is surgical resection resection. Okay, so that is what is the management of these particular patients. I hope you are able to understand. This is all about the gastrinoma which you need to understand. Now, Bohrmann's classification is used for which cancer? So can you please tell me, Bohrmann's classification is used for which cancer? So it's again a very, very simple kind of question. It is basically used for the gastric cancer. So in the gastric cancer, we have a few of the classifications which you basically have. So let's kind of talk about that. Okay, so what are the classifications which we have for the gastric cancer? The first one is basically a Stewart classification. So what is this particular Stewart classification? It basically tells us that where is this particular tumor present. So if at all the tumor is basically present 5 centimeters above to 1 centimeter above the GE junction, this is what is a Stewart's type 1. If at all the tumor is basically present 1 centimeter above the GE junction से लेकर 2 centimeters below the GE junction, this is what is a Stewart's type 2. And if at all the tumor is basically present 2 centimeters below the GE junction to 5 centimeters below the GE junction, this is what is a Stewart's type 3. Are you understanding my point? Stewart type 1, type 2, type 3. So what is type 1? Type 1 is basically when the tumor is basically present 5 centimeters above to 1 centimeters above the GE junction. What about the Stewart's type 2? This is basically present 1 centimeter above the GE junction से लेकर 2 centimeters below the GE junction. What about the Stewart's type 3? 2 centimeters below the GE junction से 5 centimeters below the GE junction. Now what you need to understand is that if at all there is a Stewart's type 1 and type 2, they are basically treated like a esophageal cancer. But if at all there is a Stewart's type 3, this is what is basically treated as a gastric cancer. Okay, so this is adenocarcinoma treated as per the gastric cancer. The another classification which we have is a Japanese classification. So this Japanese classification is for the early gastric cancer. So here what you need to understand is this is basically involving only the superficial layers of the gastric layer. Okay, gastric wall, only the superficial layers are involved. So what is the type 1? Type 1 is basically protuberant. So it is a protuberant, that's fine. Then type 2 is divided into type 2A and B and C. So A is basically elevated, B is basically fat, and from type 2C से लेकर it is starting to be depressed. And type 2 like type 3 is basically the excavated one. Okay, so what is the importance of this particular kind of Japanese classification? If at all it is involved in, let's say, type 1, type 2A, type 2B, what we can perform is basically we can perform the local resection. So submucosal dissection and the resection, all those particular things can be performed if at all there is an early gastric cancer, type 1, type 2A, type 2B. That is a clear-cut indication. In type 2C, there is a marginal indication. Like here, you can extend your criteria and you can perform the submucosal resection and the submucosal dissection. So that is what you need to understand over here. Then what we have is the Bohrmann's classification, which I was trying to talk to you about. In the Bohrmann's classification, what you have a type 1, type 2, type 3, and type 4. So what is a type 1? Type 1 is polypoidal, type 2 is basically ulcerative, type 3 is ulcero-infiltrative, and type 4 is completely infiltrative. So they keep on asking you this. Linitis plastica is which Bohrmann's type? So Linitis plastica is Bohrmann's type 4. Okay, so please try to understand. Linitis plastica is Bohrmann's type 4. Okay, so please understand, very, very important. Bohrmann's classification is basically for your gastric cancer. Now, a man opens his eyes to the pain, speaking inappropriate words and withdrawal to the pain, kind of pain. What is the GCS? Okay, so let's kind of calculate it together. So if at all there is a patient who is opening his eyes to the pain, so what is the eye opening response to of this particular patient? So the eye opening response of this particular patient is E2. Okay, so E2. Okay, then fine. Then patient speaks inappropriate words. So patient is basically speaking inappropriate words. What is the verbal response of this particular patient? Verbal response of this particular patient is V3. Okay, so it is E2, V3. Now what you have, let's talk about the motor response. And patient is basically withdrawing to the pain. Okay, so what is the withdrawal to the pain? Withdrawal to the pain is M4. Okay, so what is the answer over here? E2, V3, M4. Am I making some sense to you guys? So yeah, so what is the answer over here? It is E2, V3, M4. Now it is a very simple topic, but it's a very important topic as well. So let me just revise the GCS with you guys. Okay, so what about the GCS? In the GCS, what we have an eye opening response, we have a verbal response, and we have a motor response. So let's kind of look at them one by one. What about the eye opening response? So in the eye opening response, what we have 4, 3, 2, 1. What is the 4? The value of 4 is basically given to when the patient is basically opening the eye spontaneously. Okay, so spontaneously eye opening, that is what is the response of 4. What about the 3? 3 is basically to the painful, to the verbal speech. So when you basically go to the patient and when you talk to the patient, so on the verbal, on talking to the patient's verbal command. On verbal command, if at all the patient is opening the eyes, that is what is a kind of eye opening response of 3. Then what about the eye opening response of 2? This is basically to the painful stimulus. Then what about the 1? There is no response at all. So this is what you need to understand. Spontaneously verbal command, painful stimulus, no response at all. Okay, I hope you have understood. What about the verbal component? So in the verbal component, what we have is a 5, 4, 3, 2, 1. So what is this 5? 5 is basically when the patient is well oriented to the time, place, and person. Well oriented to the time, place, and persons. What is the verbal response of 4? Verbal response of 4 is when the patient is basically what you call as having well oriented, confused. So when the patient is confused, patient is confused, this is 4. What about the type 3, like the verbal response of 3? What is the verbal response of 3? This is what is your inappropriate words. What do you understand by the inappropriate words? It basically means that whatever the patient is basically speaking, it is not relevant to what we're talking, but it makes some sense. For example, whatever the words the patients are coming out from the mouth of the patient, they mean something, okay, but they're irrelevant to the conversation which you're having with that particular patient. So if at all they say that, you know what, or let's say the patient is starting to abuse you, let's say the patient is in the emergency and the patient has started to abuse you, that is again the verbal response of 3. What is the verbal response of 2? This is basically an incomprehensible sound. It means that whatever the sound the patient is producing, patient is trying to say something, but whatever the patient is saying, it doesn't mean anything, okay. So it is just the words or the like burger, something like that. Patient is just kind of producing some particular sound. So this is what is called as an incomprehensible sound. Okay, then what do we have? One is basically that the patient is basically what you call as no verbal response, no response at all. This is what is your 1. Okay, now let's talk about the motor response. In the motor response, what you have motor response of 6, which is basically that the patient is follows the commands. Okay, the patient follows the command. Okay, then what we have a motor response of 5. So what is a motor response of 5? Motor response of 5 is that the patient is localizing the pain, localizes the pain. For example, let's say you give the painful stimulus to the patient brings the opposite hand towards that particular point. So this is what is called as a localizes pain. Then what we have the verb, like motor response of 4. This is basically the withdrawal to the pain. So when you basically give the painful stimulus to the patient basically takes the hand back. So this is what is called as a withdrawal to the pain. Then we have the kind of motor response of 3. This is what is an abnormal flexion, and then there is an abnormal extension. So this is what is an abnormal flexion. Then motor response of 2 is abnormal extension, and motor response of 1 is basically no motor response. Okay, I hope you're able to understand. So I understand that this you would have kind of read 100 times, okay, but even if let's say a couple of you guys did not know this and you kind of gain something out of it, I would be happy. But yeah, this is absolutely important. You cannot commit a mistake in the GCS part of the kind of a thing. Okay, so yeah, please go through it. It's very, very important. Okay, now let me just tell you a couple of things related to the GCS. Okay, so let's say if at all there is a patient who is brought to you and the patient is basically intubated. Okay, so the patients are intubated. Okay, so patient is intubated, that's fine. Now when you kind of looked at the GCS of this particular patient, what you found that the eye opening response of this particular patient was, let's say, 3. The motor response of this particular patient was, let's say, 4. So if I ask you what is the GCS of this particular patient, what is the answer? So I will not wait for your responses, but I would encourage you to kind of put the responses in the kind of comment box. So the GCS of this particular patient in the idealistic scenario has to be 4 plus 3, that is 4, 5, 6, 7 NT by what you call as a 15. Okay, so if at all there is a patient who is intubated, the verbal response of this particular patient becomes NT. NT basically means non-testable. You cannot test this particular verbal response of this particular patient. You cannot assume that the verbal response is, let's say, 1 or the verbal response is 5 or anything like that. You cannot assume that. Okay, so the best, like ideally they should give you the options like 7 NT or 7 T by 15. So this should be there in the option, but unfortunately if at all they don't give you these particular things in the option and all they give you the option as 7, 8, 9 and 10. Okay, so these are the 4 options which they have given you. Still you would have to mark 7. Okay, but because see, these are wrong options, I understand that, but in the exam you cannot argue with anybody, right? So unfortunately if at all they give you the 7, 8, 9 and 10 in the options, then you have to mark 7 as an answer. I hope you have understood this particular point, because there is no other way. Okay, so you have to kind of mark 7 as an answer. Okay, so yeah, that's what you need to understand. Now lastly, in the GCS, what I want to discuss with you is something which is called as a pupillary reactive index. Okay, so what we'll discuss, we'll basically talk about the pupillary reactive index. Okay, so if I ask you about the pupillary reactive index, so normally what happens, like whenever you and I basically have like are exposed, our eyes are exposed to a bright torch light, what is going to happen? The pupils are going to get dilated. Okay, so pupils are going to get dilated. That means we have a reactive pupils. After the head injury, what happens? That if at all the head injury is very severe enough, this reactivity of the pupils is basically diminished. So when you kind of examine these particular patients and you find that both the pupils are non-reactive. Okay, so if at all both the pupils are non-reactive, this basically gives it the value of 2. If at all they say that the one pupil is non-reactive, you give it a value of 1. And if at all they say that both pupils are reactive, then it gets the value of 0. You understand my point? So don't mess it up. If at all both the pupils are non-reactive, then you basically give it as a value of 2. I hope you are able to understand this particular point. Very, 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 very important. This is what is referred to as your pupillary reactive index. So pupillary reactivity index. Okay, so this is all about the GCS which I wish to cover with you guys. So let's kind of have a look at this. There's a patient who presented oh, yeah. I'm really sorry. Okay, so Ajay, you are basically trying to say that when you kind of put the torch, there is a pupillary constriction. I understand that there is going to be the pupillary constriction, but so what basically do is that, Ajay, when you basically go and whenever, if you would have seen in the emergency room, when you basically go and examine the patients of the head injury, you basically examine them with the torchlight, you bring the torchlight and then you kind of take it away because you want to see whether the pupils are kind of constricting and dilating. So you want to see the reactivity of the pupil. I think I misspoke that, when you look at the bright light, your pupils dilate. No, not really. When you look at the bright light, the pupils constrict, but as soon as you kind of take the torch back, the pupils come back to the normal levels. I understand my point. So you want to look at this particular reactivity of the pupil. But if at all, let's say there is an EDH and it is basically compressing the nerve, what is going to happen now? Now the pupils are going to be dilated. I understand my point. So fixed dilated pupil, this is what is a feature of your fixed dilated pupil is basically a feature of your what you call as a massive head injury. So I accept, maybe I misspoke, but that's fine. But when you look at the bright light, basically what happens is the pupils constrict and then you take the torch away, you basically come back to the normal level, and this is how you look at the reactivity of the pupil. Okay, got it? Okay, so yes, right. So if at all you want to calculate the GCSP, okay, so if at all you want to calculate the GCSP, okay, so in order to calculate the GCSP, you basically subtract this. So GCS, whatever the score of the GCS which you have got, you basically subtract the pupillary reactivity score from the GCS in order to get the value of the GCSP, right? So more the pupillary reactivity score, poorer is the prognosis. That's what you need to understand. Got it? Okay, now let's move on to this particular question. So there is a patient who presented with a history of a fever and the pain in the right lower abdomen for the last 5 days. That's fine. On palpation, there is a palpable lump which was palpable in the right iliac fossa. That's fine. On laboratory investigation, the leukocytosis was present. What is the most probable diagnosis of this particular patient? Hydronephrosis, appendicular lump, tuberculosis, or the carcinoma of the colon. So what do you think? What is the answer over here? Okay, so here what you have is that there was a patient who presented with a history of the fever and there was a pain in the right lower abdomen, blah, 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 for the 5 days. On palpation, there was a palpable lump, which was palpable in the right iliac fossa. Okay, so leukocytosis was also present. So the diagnosis of this particular patient is definitely an appendicular lump. Okay, so what is the diagnosis over here? The diagnosis is an appendicular lump. And whenever you have a patient with an appendicular lump, you do not go ahead with the immediate kind of appendectomy. What you basically follow is Ochsner-Sherin regimen, where you basically give the patients fluid resuscitation and the antibiotics, and then you operate on these particular patients after 6 to 8 weeks. Okay, so you operate on these particular patients after 6 to 8 weeks. Okay, so this is what is your Ochsner-Sherin regimen. So for the appendicular lump, the management is basically Ochsner-Sherin regimen. Okay, I hope you are able to understand this particular point. Okay, now let's move on to this particular question. There's a patient underwent the surgery for an inguinal hernia kind of 5 days back. Now the patient is coming to the hospital with a complaint of the fever. What can be the most probable cause of this? So atelectasis of the lung, surgical site infection, thromboembolism, chest infection. So what do you think? What is the answer over here? So this is a question basically dealing with the post-op fever. Okay, so the causes of the post-op fever, the answer over here is a surgical site infection. So what you need to understand, these are the causes of your post-op fever. I guess this is not very clear to you guys, but what you need to understand, we have a wind, then what we have water, that we have walking, then we have wound, and then we have these wonder drugs. So this is basically divided into 5 P's. Okay, so what do you understand by the wind? So immediately on the post-operative day 1 to 2, what you basically have, you have basal atelectasis. Wind basically stands for your atelectasis. So if at all this has been asked to you as a previous question, right? If at all somebody asks you what is the most common complication of your what you call as a after splenectomy, open splenectomy, what is the most common complication? It is a basal atelectasis. Okay, why will the basal atelectasis occur? The basal atelectasis is going to occur because the lungs are not going to expand to the fullest of the amount, because whenever the patient basically takes breath, what is going to happen? There is a pain in the abdomen, and as humans what we want to kind of reduce the pain in our life. So what we do is we basically take the shallow breaths. Once you take the shallow breaths, what happens? The basal alveoli, they basically collapse, and that is why the patients develop basal atelectasis. Okay, now what about the water? In the water, this is basically the urinary tract infection. Water basically stands for the urinary tract infection, and the UTIs, they usually occur between 3 to 5 kind of days. Now after the surgery, what you want the patients to kind of get up and walk and start walking and all those particular stuff. So whenever we go to take the rounds the next day after the surgery, if at all the patients kind of getting up from the bed and walking, we are very happy, because that is going to take care of the venous circulation, is going to take care of the bowel movements, everything will be kind of sorted. But if at all, let's say the patient is immobilized, let's say the patient had undergone a pelvic fracture surgery, or let's say the patient is intubated and the patient cannot walk, in this particular scenario, the venous stasis can happen and the patients may develop deep venous thrombosis, and this is again one of the causes of the post-operative fever. Then we have done the surgery, so what can happen? The wound infection can happen. So wound infection can happen, and this is what usually presents in around 5 to 7 days. And if at all even you have ruled out everything, then you have to kind of look for any medications. Any medications are there which are basically causing the increase in the temperature in this particular patient. So in this particular question, it is very simple. After the hernia surgery, obviously the patients will not be immobilized and all those particular stuff, and this is around 5 days. So yes, definitely the answer over here is a surgical site infection. Are you understanding? Thromboembolism is going to happen if at all the patient is completely immobilized. So for example, let's say there has been a massive surgery, patient is in the ICU, patient has a pelvic fracture, long bone fracture surgery, all these particular places, there's a risk of the DVT followed by the thromboembolism. Okay, I hope you have understood this point. Now let's talk about this. Pulmonary capillary wedge pressure increases in which of the following? Okay, so hypovolemic shock, septic shock, cardiogenic shock, and anaphylactic shock. So in pulmonary capillary wedge pressure is basically going to get increase in the cardiogenic shock. So what you need to understand is that in the cardiogenic shock, what is happening? The heart is not able to kind of pump the blood outside. Okay, so the left side of the heart is not able to pump the blood to the systemic circulation. So what is going to happen? The blood buildup is going to happen. So if at all the left ventricle is not going to get empty, the left atrium will not be able to get empty. And what is going to happen? There's going to be the venous stasis of the blood inside the pulmonary circulation. And over here, if at all you get the pulmonary capillary wedge pressure, now you will get that there is a increase in the pulmonary capillary wedge pressure. Okay, so there is an increase in the pulmonary capillary wedge pressure, and that is why the answer over here is a cardiogenic shock. Okay, I hope you are able to understand this particular point. Pulmonary capillary wedge pressure is going to increase in the patients with a cardiogenic shock. Okay, I hope you have understood this particular point. It may also get increase in the late stages of the septic shock, but not in the primary, on the first stage of the septic shock. So please try to understand over here. So it is basically increasing in the cardiogenic shock. Here definitely the answer is cardiogenic shock, and in the last stage of the septic shock, it behaves just like a cardiogenic shock. So there also the pulmonary capillary wedge pressure may kind of rise. Okay, so I hope you have understood this point. Okay, now a 32-year-old male patient presented with the severe vomiting and the back pain. There's a history of childhood illness, blah blah blah, multiple skin thickening and the hyperpigmentation, which he is taking everolimus. CT scan has shown a mass in the left kidney. Comment on the diagnosis. Okay, so here this is again, like, I was really surprised to see this was a question which was asked in your FMGe exam. So guys, can you please tell me what is the diagnosis over here? It's a very detailed kind of scenario which they have kind of given. What are they basically talking about? Okay, so what are they talking about? So they are basically talking about a benign kidney condition. So which benign kidney condition they're talking about? They're basically talking about the angiomyolipoma. Okay, so what they're basically talking about? They're talking about an angiomyolipoma. Okay, so how did I kind of come to this? Okay, so forget about this vomiting and everything, that's fine, that can happen at any places. History of the childhood suggesting of multiple skin kind of a thickening. So this is what is an adenoma sebaceum. Okay, so hyperpigmentation, adenoma sebaceum, that is what you need to understand. And everolimus, this is again one of the medications for your angiomyolipoma, and the CT scan of the left kidney. Okay, so it would have been more realistic if at all they would have given you the female over here, because this is more common in the females as compared to the males, but yeah, it can also occur in the males, that's not an issue. So yeah, the answer over here is an angiomyolipoma. So what is the characteristic? So let's talk a bit about the angiomyolipoma. Okay, so what is an angiomyolipoma? As I told you that angiomyolipoma is basically a benign condition. Okay, so angiomyolipoma. What is this angiomyolipoma? Angiomyolipoma is a benign tumor which is consisting of blood vessels, muscle, and what you call as a fat. Okay, so the fat component. Okay, so blood vessels, muscles, and the fat component. So these are the three components. This is a tumor which is rising out of it. Okay, this is much more common in the females as compared to that of the males. This is the one which is associated with your tuberous sclerosis, and that is why this is associated with what you call as a skin lesions like adenoma sebaceum, along with the mental retardation. So all these particular stuff are associated in the patients with the adenoma sebaceum in these particular patients. Okay, so I hope you're able to understand this point. Okay, now the important, so usually they are asymptomatic. Okay, usually they are asymptomatic, but in these particular patients what can happen, there can happen something which is called as a Wunderlich syndrome. So what is this Wunderlich syndrome? Have you ever heard of this Wunderlich syndrome? So Wunderlich syndrome is basically a condition where what you need to understand is that there is a massive retroperitoneal hemorrhage. Okay, so what is happening over here? There's a massive retroperitoneal hemorrhage. Why? Because there is a bleeding which is happening from one particular vessel. So you understand my point? So massive retroperitoneal hemorrhage which is happening in the patients with the Wunderlich syndrome. Why? Because as I told you that this is a tumor which is involving the blood vessels also. So on the surface of the kidney, what happens? The blood vessels, they become very, very thickened. Okay, so that is what you need to understand. They can kind of rupture. Kidney is a retroperitoneal organ. So if at all these particular blood vessels rupture, what can happen? That is, there can be a massive retroperitoneal hemorrhage, and this is what is referred to as your Wunderlich syndrome. Okay, so this is what is called as the Wunderlich syndrome. Okay, now if I ask you what is an investigation of choice for these particular patients, it is a CT scan. Why? Because in these particular patients, what you have a fat component. This particular fat component is the one which is going to distinguish the angiomyolipoma from the renal cell carcinoma, because in the renal cell carcinoma patients, you never ever have this particular the fatty component. Okay, so in the renal cell carcinoma, you never ever have this particular fatty component, but in these particular patients, you do have the fatty component. Okay, so on the CT scan, this basically appears like minus 20 Hounsfield unit. Okay, so this basically appears like a minus 20 Hounsfield unit. So this is very, very characteristic. The investigation of choice is a CT scan, which basically tells you about the fat component, which is basically like how we get to know that, which is minus 20 Hounsfield unit. Okay, I hope you're able to understand this point. Treatment is observation, because it's a benign tumor, it is asymptomatic. Usually it is an observation, but if at all, let's say it is like high, like larger in size, more than 4 centimeters in size, then what you have to perform? You have to perform a partial nephrectomy, or whatever, the nephron sparing surgery or something like that. You have to kind of perform that partial nephrectomy or the nephron sparing surgery. Okay, I hope you have understood this particular point, right? So yeah, that's all about this. Now let's talk about this Dollman's procedure is done in which particular condition. So can you please help me with this important, very, very important MCQ, guys? Okay, so the Dollman's procedure is basically done in which particular condition? Can you please help me with this? So Dollman's procedure is basically done in the patients with Zenker's diverticulum. Okay, so this is basically done in the patients with the Zenker's diverticulum. Okay, so what is this particular Zenker's diverticulum? Zenker's diverticulum is basically your false diverticulum. Okay, so what is the Zenker's diverticulum? Zenker's diverticulum is your false diverticulum, which you need to understand over here. Just give me a minute. Okay, so what is the Zenker's diverticulum? Zenker's diverticulum is a false diverticulum. Why do they occur? Why do the Zenker's diverticulum diverticulum occurs. So what you need to understand is the Zenker's diverticulum, it basically occurs when there is, this is a false diverticulum. So here what is happening, that there is miscoordination between the cricopharyngeus and thyropharyngeus muscle. Okay, so there is a miscoordination between the cricopharyngeus and the thyropharyngeus muscle. So what is there? There is basically a triangle which is present over here. This is what is called as a Killian's triangle. Okay, Killian's triangle. So this is basically present between the fibers of the thyropharyngeus muscle, the above one, and lower ones are the cricopharyngeus muscle. So between these particular fibers, what you have a triangular shaped potential defect, which is basically called as a Killian's triangle. And if at all, let's say there is a, so when the cricopharyngeus basically contracts, and if at all the, sorry, when the thyropharyngeus basically contracts, if at all the cricopharyngeus doesn't get relaxed, what is going to happen? There's going to be an increase in the intraluminal pressure. There's going to be increase in the intraluminal pressure, and if at all there is an increase in the intraluminal pressure, what is going to happen? The mucosa can pop out from this Killian's triangle. So mucosa can basically pop out from this particular Killian's triangle, and this is what is called as a false diverticulum. Okay, so this is what is called as a false diverticulum. Are you understand my point? So mucosa is basically popping out. This is what is called as a false diverticulum. Now what you need to understand is that this Zenker's diverticulum, it basically starts posteriorly in the midline, and then it comes to lie on the left side. Okay, so it starts posteriorly in the midline, but ultimately it basically comes to lie on the left side. Okay, so what you need to understand over here, what are going to be the clinical features of these particular patients? So whatever the food we eat, they basically goes and gets collected in this particular Zenker's diverticulum, and over a period of time it can get kind of worsen, and there's a bad odor which can come out of it. Okay, so the clinical features are, that is what is called the halitosis. And what can happen, this particular old food basically is getting kind of deposited into that particular pouch and all those particular stuff. So in the history, they might give you that there is a regurgitation of the old food which the patient had, let's say, a couple of days back. So there is regurgitation of the old food the patient which had and all those particular stuff. So all these particular things will be given in your history, and one of the obviously along with that, the patient is going to have a non-progressive dysphagia. So what is going to be happening? There's going to be the non-progressive dysphagia. Okay, just give me a minute, guys. Just give me a minute. Okay, so yeah, so what you need to understand is that there's going to be a non-progressive dysphagia. For example, in the achalasia cardia, what you have, in the achalasia cardia, you have a progressive dysphagia. But over here, what you basically have is a non-progressive dysphagia. Now, what are the complications which can happen because of this particular Zenker's diverticulum? So what are the complications which can develop in these particular patients? So please try to understand. Lung abscess. Okay, so lung abscess, this is one of the important complications, because that food can get regurgitated and it can go into the lungs. It can lead to the pneumonitis and the lung abscess and all those particular stuff. Okay, now when we talk about the management, okay, so the important is about the management. Okay, so let's talk about the management of the patients with whatever the Zenker's diverticulum. If it is very small, if it is less than 2 centimeters, all you need to perform is a cricopharyngomyotomy. Okay, so all you need to perform is a cricopharyngomyotomy. If at all the size of this particular tumor, like this particular thing, is between 2 to 5 centimeters, now here you can perform something which is called as a Dole Mann's procedure. Okay, so what you basically do in this particular stuff is that you basically pass in this particular stapler kind of a stuff, and what you basically do is you take this particular wall between the Zenker's diverticulum down. Okay, so what you need to understand is that, let's say if at all this is the for example, if I copy this particular image, if at all, let's say this is a Zenker's diverticulum, so what we can do is we can put in a stapler, one end basically goes into the diverticulum, one end goes there, and it basically takes this particular wall down. So once this particular surgery is done, now this is how it's going to appear. Okay, so this is how it's going to appear. I understand my point. So I'll just get out of your vision so that you can actually see that. I hope you're able to understand. So once you basically fire the stapler, what you need to understand is the wall is basically taken down. Okay, so wall is taken down. So because the wall is taken down, now what you need to understand, there will be no accumulation of the food over here, and whatever the complications because of this were happening, they were not going to happen. Okay, and if at all it is more than 5 centimeters, what you need to understand, if at all the size is more than 5 centimeters, then you have to perform a diverticulectomy. Okay, you have to kind of simply exercise diverticulectomy. So you have to kind of take it out. That's what you need to understand. Okay, now what is this? This is what is a barium swallow. Okay, so what is this? This is a barium swallow, which you basically perform in these particular patients, which is a investigation of choice for diagnosing the patients with your Zenker's diverticulum. So this is what is investigation of choice to diagnose the patients with the Zenker's diverticulum. I hope you have understood this particular point, guys. Okay, now let's move on to the next question. So there's a male patient presented to the OPD with an abdominal lump and the periumbilical region, which moves at right angle to the attachment of the mesentery. What is the most likely diagnosis over here? Okay, so there's a patient who is coming to you with an abdominal lump, periumbilical region, moves at right angle to the attachment of the mesentery. What is the most likely diagnosis over here? So what we are dealing with, we are dealing with a cyst. Okay, so we are basically dealing with the cyst. So we have a like over here, amongst the options which are given, we have a chylolymphatic cyst. Okay, so there are two types of cyst. One is a chylolymphatic cyst, one is an enterogenous cyst. So what is the difference between them? The chylolymphatic cyst is basically, this is a collection of the lymph in the mesentery. Okay, so this is a collection of the lymph in the mesentery. That is what you need to understand. This is what is a chylolymphatic cyst. Now what you need to understand is that the blood supply of the chylolymphatic cyst is separate from that of the bowel. Okay, so here what you need to understand is the treatment is enucleation. Enucleation. This is what is the treatment in the patients with a chylolymphatic cyst. On the other hand, if at all there is an enterogenous cyst, so enterogenous cyst, the blood supply is basically common with the intestine, and this is basically the intestinal duplication cyst. Okay, so it is basically having attachment to the intestinal wall and everything. So over here, this is what is called as an enterogenous cyst. Over here, what is the management of this? This is basically the resection and anastomosis. Okay, so what you have to perform is you have to resect this particular part and you have to kind of perform an anastomosis. So this is what is about the enterogenous cyst, which you need to understand. And how do you diagnose clinically? What you need to understand is that this is the attachment of the mesentery. So if at all there is a cystic kind of lesion, it is going to move perpendicular to the attachment of the mesentery. It is not going to move along the mesentery, it is going to move perpendicular to the attachment of the mesentery. So this is how you kind of diagnose the patients with the kind of this intestinal cyst. They can be of two types. One is basically an chylolymphatic cyst, another one is an enterogenous cyst. Okay, so we have talked about that. Okay, chylolymphatic cyst, the treatment is enucleation. Enterogenous cyst, the treatment is resection and anastomosis. Okay, so I hope you have understood this particular point, guys. Yeah, understood? Okay, now there's a patient who came to the ER after an alkali injury to the esophagus, accidental blah blah blah, ingestion of the poison. She presents with a total dysphagia. What is the next step in the management of this particular patient? So if at all there is a patient who is coming to you after a corrosive injury, a corrosive acid, corrosive alkali injury, and now the patient has basically come to you and the patient is having a total dysphagia. Okay, the patient is not able to kind of eat or drink anything. What is the next step in the management of this particular patient? Can you please help me? What is the answer over here? So guys, the answer over here is basically a feeding jejunostomy. What you have to perform over here is a feeding jejunostomy. Okay, I hope you have understood this particular point. So yeah, the answer over here is a feeding jejunostomy. That is what you have to kind of perform. Okay, right. So why? Because the patient is not able to kind of eat, drink anything. You have to basically perform in feeding jejunostomy. Injury. Okay, so the corrosive injury to the esophagus. Corrosive injury to the esophagus. Okay, so what about the corrosive injury to the esophagus, guys? What about the corrosive injury to the esophagus? What you need to understand, obviously they are usually suicidal. Okay, suicidal hote hain mainly, and what can happen is that when the patient basically drinks the alkali or acid or whatever, what can happen is that what can happen because of this is that okay, so if at all there is a patient who is kind of drinking an acid or alkali or whatever, what can happen is that the intestine of obviously the esophagus, the lining can get kind of injured and all those particular stuff. And if at all there is a minor injury, okay, if at all there is a minor injury, what is going to happen? It is just going to get burnt, or it's just going to have the injury to the epithelium of that particular esophagus. But if at all there is a major injury, then what's going to happen? There can be a through and through rupture of the esophagus. Okay, there can be through and through rupture of the esophagus, or there can be esophageal perforation. So the patients can come to you either in the form of an esophageal perforation. So if at all there is a esophageal perforation, that is kind of very grave situation, because now the acid alkali has kind of reached to the mediastinum and it is causing the mediastinitis and other problems in the mediastinum and everything. That is a very bad scenario. On the other hand, what can happen? There can also happen that there is an injury to the esophagus. Yeah, there is an injury to the esophagus, and that's it. Okay, so just the lining of the esophagus is basically getting injured. That's it. Okay, so I hope you're able to understand this point. So this is what you need to understand about it. Now, whenever there is a patient who is coming to you with a corrosive injury, okay, so whenever there is a patient with a coming to with a corrosive injury, what is your thoughts about the endoscopy? Endoscopy should be done or not? Endoscopy should be done or not? So please try to understand early endoscopy. Early endoscopy is the norm. Okay, so because when the patient has just come after the injury, okay, if at all you perform an early endoscopy, you will be able to assess the severity of the injury and everything. But delayed endoscopy is not possible, because now the esophagus will become fragile, and now if at all you try to perform endoscopy, what can happen? The esophageal perforation might happen because of your endoscopy. So early endoscopy, let's say within 2 to 3 days, that is something which is performed if at all there is a patient with a corrosive injury. Okay, so now let's move to the next question. There is a patient which is coming to you with the swelling of the neck shown in the image. On further evaluation, there's the swelling which basically moves with the protrusion of the tongue. What is the most likely diagnosis of this particular patient? Is it like a thyroglossal cyst, sebaceous cyst, dermoid, or lipoma? So what do you think? What is the answer over here? What is the answer over here, guys? The answer over here is definitely a thyroglossal cyst. Okay, so what is the answer? It is a thyroglossal cyst. So let's talk about this particular stuff in lot of details. Okay, so let's talk about this particular stuff in a bit more detail, because this is a very important topic for you guys. Okay, so what you need to understand is that, let's say we have this particular tongue. So what can happen from this particular tongue? That is the thyroglossal duct. Thyroglossal duct can basically come down, and what can happen is this particular thyroglossal duct, it basically goes around the hyoid bone, and then it basically comes down, and it basically gives rise to the formation of a thyroid gland. Okay, you understand my point? So this is what you need to understand. This is what is a hyoid bone. So this thyroglossal duct, so this thyroglossal duct, this basically usually disintegrates. Okay, this disintegrates. But if at all this particular thyroglossal duct, if at all it fails to disintegrate, okay, if at all this fails to disintegrate, then what you need to understand, if at all this fails to disintegrate, then it leads to the formation of a cyst, which is basically called as a thyroglossal cyst. Okay, so the remnant of this particular thyroglossal duct is basically a thyroglossal cyst. Okay, so what is a thyroglossal cyst? Thyroglossal cyst is a condition where there is a remnant of a thyroglossal duct. That's fine. So thyroglossal cyst. So this is basically a remnant of your thyroglossal duct. What about the clinical features of these particular patients? So this is basically usually a midline swelling, which basically moves with deglutination and protrusion of the tongue. Okay, so this is the swelling which basically moves with the deglutination and the protrusion of the tongue. Very important. Okay, that's fine. Okay, now if I ask you what is the most common site of this particular thyroglossal duct, thyroglossal cyst, please try to understand. It is subhyoid. Okay, so just below the hyoid bone, subhyoid. This is the site where the thyroglossal cyst is most commonly found, subhyoid. Okay, now this is basically midline swelling. All those particular things are fine. Now, what are the risk? What is the risk factor with this particular swelling? Okay, if at all you don't manage it in a proper manner, it can land up into infection, or it can land up into a kind of cancer. Okay, it can basically get transformed into a cancer. Which cancer it can get transformed into? A long-standing thyroglossal cyst is a risk factor for your papillary carcinoma of thyroid. Okay, so long-standing thyroglossal cyst is a kind of risk for your papillary carcinoma of thyroid. Okay, so all these particular things are important. Now, what else over here? So, what about the treatment? So, you have to kind of manage these particular patients, because if you don't manage these particular patients, then the recurrent infection can happen and it can basically rupture. So, the management is basically with the cyst trunk operation. Cyst trunk operation. This is what you need to understand. In this, what you basically remove is you remove the thyroglossal cyst along with the tract, along with the central portion of hyoid plus the base of the tongue. Are you understand my point? So these are the things you basically remove in the patients with the thyroglossal cyst. Okay, so this is what is called as a cyst trunk operation. This is how you basically perform in these particular patients. Okay, so I'll quickly revise this because for FMG this is absolutely important. So what you need to understand, thyroglossal cyst, this is basically midline swelling which is basically occurring, and this basically moves with the degglutination and the protrusion of the tongue. The most common site is the subhyoid. The risk with this particular stuff is that it can land up into infection or the cancers. Now, other things are relevant for the diagnosis. Obviously, you can do an ultrasound, you can do an FNAC, all those particular things. This is more common in the females as compared to the males. That's all fine. Now, the management is the cyst trunk operation. What you basically do is you remove the thyroglossal cyst, tract, central portion of the hyoid bone, and the base of the tongue. Now, what you need to understand is that this is what is about the thyroglossal cyst. What about the thyroglossal fistula? What about the thyroglossal fistula? Is it a congenital swelling or is it like an acquired swelling? So please try to understand, this is never congenital. Okay, so this is never congenital. This is always an acquired swelling. Okay, so this is always an acquired swelling over here. Are you understand my point? So the thyroglossal fistula is always an acquired swelling. It is never ever a congenital swelling. Okay, so what happens with this particular thyroglossal fistula is that probably there is a thyroglossal cyst which got infected, which got ruptured, and now there is a fistulous communication which is present over here. Okay, for what about the management of the thyroglossal fistula? The management of this is again a cyst trunk operation. Okay, this is again a cyst trunk operation. Okay, so that is what you need to understand over here. Okay, right, now let's move on to the next question. The next question which we have over here is that there is a 11-month baby which has been brought to the emergency with a pain in the kind of abdomen with the multiple episodes of vomiting. On examination, there was a mass which was palpable on the right kind of lumbar region. The barium enema image has been shown to you. What is the most likely diagnosis in this particular patient? Okay, so here what you're basically seeing is a barium enema kind of image in this particular patient. So what is the diagnosis of this patient? Is it like an intussusception, volvulus, malrotation of the gut, or whatever the duodenal atresia? What is the diagnosis over here? Okay, so can you please help me with this? What is the diagnosis over here? The diagnosis over here is definitely an intussusception. What you're basically seeing over here is a characteristic claw sign. Okay, so let me just cover a bit about what you call as your so let me just cover a bit about your intussusception. Okay, so let's talk about a bit about your intussusception. Okay, so let's talk about a bit about your intussusception. In the intussusception, what is going to happen? There's going to be the telescoping of a bowel into the other. Okay, so the one part of the bowel is basically telescoping into the other. This is what is basically happening in the patients with the intussusception. Because of this, what happens? The patients basically come to you with a intestinal obstruction. Okay, so here what can happen? There can be a palpable lump in the what you call as a iliac fossa. So there can be a palpable lump in the iliac fossa. All these particular things are going to be there. Now the important things which they keep on asking you over here is the diagnosis. Okay, so on the barium enema, what you basically find in the barium enema? So in the barium enema, what you basically find is a claw sign. You can also find a coiled spring appearance. Okay, so the coil spring appearance and the claw sign, these are the things which you basically find in the barium enema. Now, what about the ultrasound? When you perform an ultrasound in these particular patients, what you basically find in them? So in the ultrasound, what you basically find is a pseudo kidney sign, and you also find a target sign. Okay, so the target sign or a pseudo kidney sign is something which you basically find in the patients with what you call as an ultrasound. Okay, on ultrasound, what you basically find is a pseudo kidney sign or a target sign. Okay, I hope you're able to understand this particular point. So yeah, this is what you basically find on an ultrasound. Okay, and on the plain x-ray, what you basically find is a air crescent sign. Okay, so the air crescent sign. Okay, so the simple air crescent sign is something which you basically find on the patients with the plain x-ray. Okay, so these are the ways in which you basically diagnose these particular patients. What about the management? So when we talk about the management, if at all there is no peritonitis, there is no features of peritonitis which is present in these particular patients. If at all there is no peritonitis in these particular patients, what you basically do is you have to kind of what you call as perform an enema. Okay, so enema you basically perform. You can also perform a gastrograph in enema. So what you can perform also is a gastrograph in enema. Okay, so this can also help, but if at all you find that there are features of peritonitis, if at all they are present, okay, if at all the features of the peritonitis are present, then in that particular scenario what you have to perform is, then you have to obviously perform a exploratory laparotomy. Okay, so you have to perform exploratory laparotomy over here. I hope you are able to understand this particular point. Very important. Okay, understood, guys? So these are the important things about the intussusception which you need to understand. Now there is a pregnant lady undergoes a routine kind of abdominal ultrasound, and the following findings are noticed. What is the diagnosis of this particular patient? Simple hepatic cyst, amoebic liver abscess, gallstones, appendicitis. Okay, so what is the diagnosis over here? Can you please help me, guys? What is the diagnosis over here? Okay, so the diagnosis over here is definitely a gallstone, guys. Okay, now it might sound very silly to you guys, but if at all you commit a mistake in questions like this, that is absolutely kind of the end of the story for you guys. Okay, so what you need to understand is this is a characteristic posterior acoustic shadowing. What you're basically finding over here, this is what is a characteristic posterior acoustic shadowing. Okay, so what are you basically finding over here is a characteristic posterior acoustic shadowing. This is what is basically a feature of your gallstones. Okay, so ultrasound is an investigation of choice. Ultrasound is a investigation of choice for your gallstones, and this is what you're basically seeing over here. Okay, so ultrasound is an investigation of choice for gallstones, and this is what is being shown in this particular image to all of you guys. Okay, I hope you have understood. A very important image. I hope you have understood. Okay, right. Now, what is this? What is this particular image trying to show you? This is basically a porcelain gallbladder. Okay, so what about this particular porcelain gallbladder? This is basically a risk factor for gallbladder carcinoma. So this is a risk factor for the gallbladder carcinoma, and over here what you have to perform is a prophylactic cholecystectomy. Okay, so you have to perform a prophylactic cholecystectomy in the patients with a porcelain gallbladder. Okay, so yeah, that's what you have to kind of perform. Okay, what is this? This is basically a calcified gallstones, and these are basically present only in the 10% of the patients. Okay, only in the 10% of the patients what you basically find is a calcified gallstones. Okay, so only in the 10% of the patients what you end up finding is a calcified gallstones. I hope you have understood this particular point, guys, right? Okay, now let's talk about this. So there is a patient, there's an x-ray of the patient with an abdominal surgery is shown below. The patient is in the state of an ileus. What is the most common cause of the prolonged paralytic ileus? So in other words, they are basically trying to ask you that there is a patient who is basically present in the state of a paralytic ileus. What is the most common cause of a paralytic ileus? Okay, so can you please help me? What is the most common cause of the paralytic ileus? The answer over here is hypokalemia. Okay, so hypokalemia is the most common cause of a paralytic ileus. Okay, so reduction in the potassium levels, this is the most common cause of your paralytic ileus. Okay, I hope you've understood this particular point, guys. Yeah, so this is the most common cause of your paralytic ileus. Okay, right. Okay, now what we'll do is, guys, we'll just break for around 10 minutes and we'll meet back. So it is around 9:47. We'll restart it at around 10 o'clock. Okay, so around 10 o'clock we'll restart the class. Okay, so let's kind of have a small tea break or whatever you want to take it. Just have a small break. We will get back after at around 10 o'clock. Okay, at 10 o'clock we'll get back. So hi guys, let's move on to the next question. Okay, so there's a patient post-surgery developed a low-grade fever on day 5. Okay, on day 5, and there was a pain in the calf and the pedal edema. So yes, somebody had already told that the answer over here is a DVT. We have already talked about this. So this is again like one of the causes of your post-op fever. Okay, so after surgery, if at all the patient develops fever, this is again one of the kind of causes of that. Okay, so DVT. Understood, right? Got it? Pretty simple, nothing major about this. Yo guys, welcome back. I hope I'm audible, visible properly, right? Yep. Okay guys, right, yeah. Okay, now let's move on to the next question. So this we have already covered, the post-op fever. So we have the atelectasis just on the post-op day 1. What we have is an atelectasis. Then we have the wind, then water, that is your urinary tract infection, then walking, that is your DVT with the thromboembolism, then we have a wound infection, and then finally we have the drugs. Okay, so 5 W's of your post-op fever. Okay, I hope you have understood this point. Now, what is the ulcer? Like in this particular image, what is the type of an ulcer? What are you basically trying to see? Okay, so is it like a malignant ulcer, arterial ulcer, venous ulcer, or the trophic ulcer? The answer over here is an arterial ulcer. So what you need to understand that there is an ulcer which is basically occurring on the lateral aspect of the leg, and surrounding, what you need to understand that there is a thinning of the skin. So this is what is a patient who is suffering from a PVD, and what is this? This is basically an arterial ulcer. So what is this? This is basically an arterial ulcer which you are basically dealing with. You understand my point? So arterial ulcer, thinning of the skin, all this particular stuff, right? I hope you have understood. Got it? Okay, right. Now there's an alcoholic patient with a okay, right? So this is an arterial. So okay, so let's me talk about the other things as well. Okay, so let's say if at all I give you a scenario that there is a patient who is kind of there, who has an ulcer, and this particular ulcer it's a chronic ulcer. So what do you understand by a chronic ulcer? What do you understand by a chronic ulcer? Chronic ulcer basically means that the duration of the ulcer has been more than 3 months. Okay, so they say that the patient is basically having the ulcer which is for more than 3 months. And now what I'm trying to ask you is that what is the next step in the management of this particular patient? Okay, so what is the next step in the management of this particular patient? So if at all there is a patient who is having a chronic ulcer, what is the next step in the management of this particular patient? Okay, so the next step in the management of this particular patient is a biopsy. Okay, why biopsy? Because you want to rule out the malignancy. So you want to rule out the malignancy, and that is why what you have to perform over here is a biopsy. So what type of malignancy which can happen over here? The squamous cell carcinoma. Okay, so the low grade squamous cell carcinoma. So what are we trying to rule out? We are basically trying to rule out the Marjolins ulcer. So what is a Marjolins ulcer? Marjolins ulcer is basically a malignant ulcer which is going to happen in the patients who are having a long-standing non-healing ulcer. Okay, so in the patients with a long-standing non-healing ulcer, long-standing basically means a chronic ulcer that is more than for the period of more than 3 months and all those particular stuff. In these particular patients, there can be a development of a malignant ulcer, and if you take a biopsy of that, that is what you basically get as a low-grade squamous cell carcinoma. Okay, you understand my point? So this is what is a low-grade squamous cell carcinoma. This is what is a Marjolins ulcer. That's what you need to understand. Okay, so two things which they keep on asking you. What is the next step? Next step is biopsy. Why is a biopsy? Because you want to rule out the malignancy. And yeah, what is the most common type of the histopathology example which you biopsy which you basically get, which is a low grade squamous cell carcinoma. This is what you basically get in these particular patients, right? Okay, now what about the venous ulcers? So venous ulcers, what is the most common location of the venous ulcer? Can you please help me with this? So yeah, the venous ulcer, what is the most common location of an venous ulcer? So please try to understand the most common location of the venous ulcer is the medial aspect of the leg, that is lower 1/3. Lower 1/3 medial aspect of the leg. This is what is the most common location of your venous ulcer. I hope you are able to understand this particular point. Very, very important. Okay, so medial aspect of the leg, lower 1/3. Okay, so what is this called as? This is what is called as a Gator's area. Okay, what is this called as? This is what is called as a gaiter's area. Gaiter's area, medial aspect of the leg, lower 1/3. Very, very important. Okay, I hope you have understood. This is what is your venous ulcer. Understood? Yes or no? Yes, I hope you have understood. Now, there is a patient, there is an alcoholic patient with loose motions, a few days present with the pain, blah, 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 and the right hypochondrium and the fever. Ultrasound shows that there is a liver abscess of 75 kind of cc. What is the next step in the management of this particular patient? So first of all, tell me, what are we dealing with? Are we dealing with a amoebic liver abscess, or are we dealing with a pyogenic liver abscess? So what do you think? What are we dealing with? So I hope that you are saying that we are dealing with a amoebic liver abscess. Okay, so I hope we are saying that we are basically dealing with a amoebic liver abscess. Okay, so why this is an amoebic liver abscess? Can you please help me with this? Why this is an amoebic liver abscess? So why? Because I hope you're able to understand that here in the history, what they have given you, that they have given you that there is a loose motions. Okay, so what are there? There are loose motions. Okay, so there is a loose motion which is there, and there is an alcoholic patient. So alcoholic patient with the loose motions, this is what is a liver abscess. That is an amoebic liver abscess. I hope you are able to understand this particular point. Okay, and what about the management of this? So the management of this is medical management. Okay, so what is the management? It is a medical management which you basically have to kind of perform here in the amoebic liver abscess, metronidazole. Okay, right? Are you understanding my point? Right. Now let's talk a bit about your amoebic liver abscess. Okay, so let's talk about your amoebic liver abscess. So if I talk about the amoebic liver abscess, what is a causative organism? What is a causative organism for this? It is Entamoeba histolytica. Okay, so what is this? This is an Entamoeba histolytica. Now over here, what is an infective stage? The infective stage in these particular patients is quadrinucleate cyst. Okay, so please try to understand the infective stage is the quadrinucleate cyst. Okay, so quadrinucleate cyst is an infective stage. What happens is that this particular quadrinucleate cyst is basically ingested, and this basically comes to your intestine. Now, if I ask you which part of the intestine this particular quadrinucleate cyst usually opens up, so please try to understand this quadrinucleate cyst is opening up in the what you call as a cecum and the ascending colon. Okay, so this is basically opening in the cecum and the ascending colon. The quadrinucleate cyst basically opens up in the cecum and the ascending colon, and over here there is a formation of an ulcer. What kind of an ulcer? So there is a formation of a flask shaped ulcer. So there is a formation of a flask shaped ulcer. Now what you need to understand that there is a blood vessel which is kind of going from here. So the trophozoites. Okay, so the quadrinucleate cyst, when it basically opens up, what it basically gives out is a trophozoites. Okay, so it basically gives trophozoites which are basically present in this flask shaped ulcer. So in this particular flask shaped ulcer, what you basically have is the trophozoites. These trophozoites can enter into the blood vessel and they can basically travel to the liver. In the liver, what it causes is it causes an enzymatic degeneration. Okay, it causes an enzymatic degeneration which leads to the development of your abscess. Basically leads to the development of your amoebic liver abscess, which basically consists of your hepatocytes, RBCs. Okay, so dead hepatocytes and the RBCs, this is what is kind of there. And what is this referred to as? I hope you're able to understand that this is what is called as an anchovy sauce pus. Okay, so this is what is referred to as your anchovy sauce pus. What is this anchovy sauce pus? This is an accumulation of this particular like this reddish brownish colored kind of abscess in that particular kind of a liver. Okay, so this is what you need to understand over here. Okay, so yeah, this is what you need to understand, right? Got it? Now, what about the management of this? So whenever you have this particular amoebic liver abscess, how are you going to manage these particular patients? The management of the amoebic liver abscess is with metronidazole. Okay, so what is the management? The management is with the metronidazole. The treatment of choice is basically your metronidazole. Metronidazole. Before we talk about the treatment of choice, if I ask you, what about the investigation of choice for the amoebic liver abscess? So can you please help me? What is an investigation of choice for an amoebic liver abscess? The investigation of choice for the amoebic liver abscess is what you call as a serology. Okay, so serology, ELISA. Okay, so please do not mark it as a CT scan or any other thing. Okay, if they ask you what is a radiological investigation of choice, and yes, over here the answer is going to be the CCT. That's fine. Okay, CCT. But if they ask you overall, what is the investigation of choice? The investigation of choice is basically serology. I hope you are able to appreciate it. Overall, the investigation of choice is your serology. Okay. Now, why not D? Somebody had asked, why not D? Pancreatic drainage. Because the diagnosis over here is an amoebic liver abscess, and in the amoebic liver abscess, the treatment of choice is your metronidazole. Metronidazole. I understand my point. Okay, I hope you got this right. Live life king size. I hope you understood this point. Okay, so this is all about the amoebic liver abscess, which we need to kind of cover over here. Now, there's a 22-year kind of old man underwent a surgery of the chest after the road traffic accident 1 year back. The image of the lesion has been shown in this particular figure. What is the most probable diagnosis of this particular patient? So I'll just zoom into the image. What is the diagnosis over here? What do you think? Is it like a hemangioma, hypertrophic scar, keloid, or the neurofibroma? What do you think? What is the answer over here? Okay, so the answer over here is definitely a hypertrophic scar. So I'm pretty sure that you guys know this, but what you need to understand is that you need to differentiate between the hypertrophic scar and the keloid. In the hypertrophic scar, what is there? That both are the scar abnormalities, that is fine. But what you need to understand is that the hypertrophic scar basically is maintained within this kind of the margins of that particular scar. Okay, but what you need to understand, the keloid, it basically goes beyond the margin of that particular scar. It is not a keloid, it is a hypertrophic scar. Okay, so keloid will go beyond the margin of this particular scar, but over here, as you can see, it is basically maintained within the boundary of that particular scar. That is why this is a hypertrophic scar and this is not the keloid. Okay, I hope you have understood this particular point. Okay, now there is a middle-aged kind of a female with the history of a radiation exposure with the painless kind of a slow growing midline anterior swelling. After 6 months, there's a bilateral cervical lymphadenopathy. So after 6 months, the patient had a bilateral as a cervical lymphadenopathy also developed, and surgery was done, and the image has been kind of given in the biopsy. What is which of the following is not true? So FNAC is not diagnostic. Okay, so which of the following is not true? Okay, so first of all, I want to know the diagnosis. So what do you think? What is the diagnosis of this particular patient? So please put the diagnosis in the comment box. Okay, now if you have put the diagnosis, that's great. Now, which of the following is not true? So FNAC is not diagnostic. Nuclear features are the characteristic of this particular tumor. Spread is through the lymphatics. It is having an excellent prognosis. So what is our answer over here, guys? FNAC is non-diagnostic, is not true. FNAC is the investigation of choice. So this is what is an investigation of choice for the patients with this. Okay, so nuclear features are characteristic. Okay, so we'll talk about this. So what is the diagnosis over here? This is what is a papillary carcinoma of thyroid. Okay, so let us talk about the papillary carcinoma of thyroid in detail. Okay, so let's talk about the papillary carcinoma of thyroid. So what about the papillary carcinoma of thyroid? If I ask you, this is the most common type of a thyroid malignancy. Yes, this is true. This is the most common type of a thyroid carcinoma. This is also the one which is having the best prognosis. Okay, so this is also the one which is having the best prognosis. Okay, so this is the one which is having the most common thyroid cancer, and this is also the one which is having the best prognosis. I hope you have understood this particular point. Now, other things which you need to understand over here is that what is the genetic mutation which is associated with the papillary carcinoma of thyroid? It is a BRAF gene mutation. Okay, so BRAF gene mutation are the ones which are basically associated with this papillary carcinoma of thyroid. Okay, so BRAF gene mutation associated with the papillary carcinoma of thyroid. Now, what is the risk factor? So important. What are the risk factors for these particular stuff? Okay, what are the risk factors? So the risk factor is, first is the radiation exposure. So radiation exposure, which would have happened in the childhood, probably because of, let's say, some malignancy over here, like say head and neck malignancy or something like that. The patient would have received the radiotherapy in the childhood. That is one of the important risk factors. Another one is the long standing thyroglossal cyst. Okay, so long-standing thyroglossal cyst. Are you understand my point? So radiation exposure in the childhood and the long-standing thyroglossal cyst, these are the important risk factors for the development of your papillary carcinoma of thyroid. Now what you need to understand is what is the presentation. Okay, so if you talk about the presentation of the patients with this particular papillary carcinoma of thyroid, what is the presentation? So patients can come to you with either the lateral aberrant thyroid nodule, which basically means that, you know what, there's not a midline filling, but the nodule is basically in the lateral aspect of that particular thyroid gland. And this particular lateral aberrant thyroid nodule, this is also moving with deglutination. This moves with deglutination, but it doesn't move with the protrusion of the tongue. It moves with deglutination. Okay, that's, or what can happen, there can be an occult thyroid malignancy with early lymphatic mets. Okay, so what do you understand by occult? Occult basically means hidden. Okay, so this basically means hidden. So there is a hidden thyroid malignancy. It means that in the thyroid, when you are palpating, there is not a very important nodule which is basically getting palpated. Okay, so hidden thyroid malignancy with an early lymphatic spread. So what you need to understand is that in the patients with the papillary carcinoma of thyroid, what is more common, hematogenous spread or the lymphatic spread? So lymphatic spread is common. So here in the midline, there will be no swelling, nothing, but there will be a lymph nodes which are palpable. So that is very, very important. Occult thyroid malignancy with the early lymphatic metastasis, okay, or with the neck swelling, whatever you want to call it. Okay, now when we talk about the the diagnosis, so FNAC is the investigation of choice, and on the FNAC, what you're going to find? You're going to find a samoma bodies. So these particular samoma bodies are the ones which we had seen over here. Okay, so these are the samoma bodies which you had kind of seen over here. So this is what is the samoma bodies. I hope you're able to appreciate it. Right now, these are the inclusion bodies. Okay, so these are the inclusion bodies which you basically get in the patients with the the papillary carcinoma of thyroid. Okay, so that is what you need to understand, samoma bodies. Or what you can have, you can also have what you call as a orphan NEI nuclei, okay, so orphan NEI nuclei, and you can also have a pseudo grooving. Okay, so pseudo grooving. So all these are the features which you basically get in the patients further, which are the investigation which you basically get on the FNAC in these particular patients. Okay, I hope you have understood this particular point, right? And finally, about the management. So in the management, what you need to understand, you perform a total thyroidectomy with plus minus modified radical dissection, MRND. Okay, so this is how you're going to manage the patients with the papillary carcinoma of thyroid. Okay, so this is important as far as the papillary carcinoma of thyroid is concerned. Okay, now guys, what I'll do is I might end this particular session at this point of time, and I have some kind of work, I'll have to kind of leave, but that's fine, not an issue. So what you need to understand is that day after tomorrow, for the FMG students, it's very, very important. So there are a few MCQs which are remaining in this particular stuff as well. So on 24th, I have another session with you guys where I'll be covering the 100 most important images for you guys. So what I'll do is I will cover all the most of the important topics in the form of an images in that particular stuff. I have got a lot of requests for the sutures quite a lot of times, so I will cover the sutures also on that particular day. So on 24th, I will have that 100 most important images wala session, so we will kind of cover that over here. Okay, so this was a pretty small session. I understand that it was only 2 hours kind of a session, but yeah, I hope you gained something out of it, and I will meet back with you guys again on 24th. Okay, 24th evening, 8 o'clock. Again, the session basically is going to start. Okay, thank you so much for patiently listening. I hope you gained something out of it. These are all the important stuff. I will just wait for a couple of minutes if at all you guys have some doubts to ask or anything if you wish to ask. Otherwise, I'll just kind of end the session at this point of time. Okay, all okay? Sure. See you on 24th, guys. Bye bye. See you on 24th.